Pat Salber with Health Innovation TV, and it's my pleasure today to introduce Sam Nussbaum, who's the Chief Medical Officer of WellPoint. And we actually were just reminiscing and realizing that we've known each other for quite a long time. Would you like to say a few words about what you're doing at WellPoint?
Sure, Pat. First, it's really terrific to be with you this afternoon and actually to be at Datapalooza because there's so much innovation that's taking place. Earlier today, we had a chance in a panel to discuss a number of new payment models, what we'll term pay for value, moving us from fee-for-service unit reimbursement to reimbursement that values outcomes, that values evidence-based care, that values clinical knowledge, that values putting the patient first. So here's what we've done at WellPoint. We believe that the model that we need to be on a journey toward is one where there's more and more global payment, shared savings, accountability by providers and with us as an information and a trusted partner to have better models of payment, better patterns of care, care that makes a difference in people's lives. So how do we get there?
So what I'd really like you to emphasize for me, Sam, is how do you get to value that means something to the patient? We're used to people saying, oh, well, I'll buy it because the waiting room was really nice or the location was good or the doctor was nice to me. But we don't necessarily say, I want you to pay more for the guy who did a really good job with my heart attack.
Sure, Pat. And I think one of the foundations that we're building on is a foundation of a personal care, primary care physician. We pioneered this work in our patient-centered medical homes. We have now advanced this model across all of the states in which we do business as either Anthem Blue Cross Blue Shield or in some of our other, our AmeriGroup companies. And what we have done is said that we will pay doctors more. We'll pay doctors more when they get better outcomes of care. So we look at all of the quality measures in diabetes and preventive services. We look at measures that historically have been utilization measures, such as emergency room visits that are unplanned, or hospitalization or rehospitalization. And we look at areas that we know we can achieve better quality at a lower cost, such as how we use pharmaceuticals, particularly generic pharmaceuticals. We build that entire model, and we pay physicians. Initially, we've paid them a management fee, but going forward, we're going to be paying shared savings based on the trend for our non-patient-centered primary care compared to the trend for patient-centered primary care. To be very specific, what we started doing is we're paying more for primary care services. We have paid management fees. We've paid more for quality, and importantly, we're moving to a shared savings model. But these are based on many, many factors. So it's a lot of focus is on how much information we can provide physicians at the point of care, how we can get the consumer engaged in shared decision-making to make the right decisions, decisions that are patient preference decisions, patient choice decisions. There are all of these elements that we're building into the model, and our first results in our patient-centered medical home models over the last 3 years, have been nothing short of phenomenal. Let me repeat that. Over the last 3 years, we began 10 patient-centered medical homes, and those results are phenomenal. Let me just give you the highlights. In each instance, costs have either decreased or they have been less than medical trend. Quality, even more important, quality of care improved. So whether it was diabetes care, preventive care, care for heart disease. And most important to your question, the actual experience of care was preferred by patients having this patient medical home.
So if I heard you right, it sounds like you just met the triple aim.
It would be terrific if our healthcare system can get there, isn't it? I mean, this really, I think one of the great things that Don Berwick through IHI and then at CMS gave us is this vision of better health, which is something that we really need to achieve, better health care, and importantly, at a more affordable care, so better cost of care. That result was achieved in those medical homes, and that's why we were so excited to expand the program to 20,000 today, 20,000 primary care doctors, to over 1 million of our members. We still have a journey. We hope to have, by the end of next year, the end of 2014, 75 to 80% of our networks paid in this model. But it's not the only model. Let's be clear. There are ways of rewarding hospital for delivering better care, safer care, more patient-centered care. And there are models of working with larger integrated organizations, and we have experience in both with ACOs and with hospitals. But as a foundation for each of these models, having the patient at the center of care, having the physician as the coach, the quarterback, the coordinator, and ultimately, if you have complex illness, having a care team surrounding you is what the future of healthcare will be about.
That's fantastic. The question I have, so you talk about this being about 1 million of your patients. You have 20 million patients?
Actually, about 36 million.
36 million patients. I believe you said it was about a tenth of all insured people in the country.
1 in 9 carry that.
1 in 9. And so I as a former Kaiser Permanente physician, I understand how this works in integrated systems, but do you think this is going to work in rural areas? Do you think this is going to work where physicians are in onesie, twosie practices, or do you think we're going to have a new model of care in areas where those are the dominant models?
I mean, you really are emphasizing all the capabilities in what a Kaiser or a Geisinger or a highly integrated system can deliver. And it's really coordinated care, better quality, lower cost. How do you do this in networks? And so I think this is where critically information at the point of care and support and team care comes to play. Now, it turns out that in Kaiser, you had everyone within your facility, your physical environment. So we have to create more of a virtual environment. So let me give some examples of how we can get this done, and particularly how we get this done in primary care. We are encouraging physicians to work together. So while today we still have the majority of physicians, even if they work for health systems, practicing in small practices. So it starts with information. And we are providing information at the point of care. We're understanding based on claims, and we get pharmacy claims daily, laboratory information, all of the claims that we get, and we can look at clinical algorithms to see when care is not state-of-the-art. So we give that information back increasingly real time to
How do you do that? Via their electronic health records?
Great question.
You're getting away from the fax machine, I hope.
Yeah, away from the fax FAX machine, but to the fax FACTS machine. So here's an example of using a portal. Our ultimate goal is to have a longitudinal integrated patient record, but we're not there yet. So what we've been able to do is take what we call our member medical history. So all the information we have on any of our members, literally real time on drugs, on laboratory data, on claims, there is a little bit of a delay, but not much. And we provide that information at the point of care. So we are using an organization, a company called Availity. Availity does transactional information with physicians' offices today. A lot of it is around eligibility and payment, but we are delivering through that Availity portal at the point of appointment this information. Now, it is not into the integrated patient record, but that's our goal, to get it there. And that is an example of how then at the point of care, you can see if several physicians are prescribing different drugs, if certain procedures have been done, and most importantly, we know, sadly, that about 45% of care delivered in America doesn't meet the standards of quality, of evidence-based care, and so that's the work that we're doing too. But that's only a piece of it. There's so much that we're excited about it at WellPoint.
Well, good. I have one last question that I have to ask you, because we're at Health Datapalooza, and it's all about sharing data. And I know that WellPoint has just an incredible amount of rich data. And so you're sharing it with the doctors, and that's fantastic. You guys see I have a little blue button pin on here. Yes. So the question is, are you going to share it with patients? And more importantly, are you going to share this with everyone, maybe in a de-identified aggregated fashion, but just to contribute your data to the knowledge base and all the incredible developers that are here at this conference that are trying to create solutions based on robust data.
Yeah, and Pat, that's such an important issue. So let me tell you where we are sharing our data. We are part, in fact, initially provided the lion's share of information early on to the mini Sentinel system. So we're working with the FDA and many other health plans to provide information to look at the safety of drugs after they've had their approval, after their NDA. That's an area that we're working on. We're working with CDC on PRISM, looking at vaccine safety. We're working through many state consortia on data consolidation and looking at both clinical performance and public health performance. So whether it's in Wisconsin or California, we're involved in many of those initiatives. We have a subsidiary organization, company called HealthCore, that in fact is partnering with many academic organizations. We have over 100 projects that look at outcomes. So these are all of the ways that we're sharing data, including getting information to our members so they can make the best care decisions.
Well, it's a pretty exciting time, and I thank you for sharing all the things that WellPoint is doing. It's been an incredible journey in healthcare over the last 20 or 30 years as we've gone from paper and physician dominance to electronic, big data, and patient centricity. So thank you very much, Sam.
Thank you, Pat. It is a journey, but it's a journey that we're all collaborating to achieve a better result for all Americans, which is a safer, more effective, better quality care, and at a more affordable price. I think that's the responsibility that we all have working together. It's great.
And that's the last word. Thank you very much, Sam, and thank you on behalf of Health Innovation TV.